population-based teaching as applied to obstetrics. Obstetrics is a high-risk specialty. It requires availability of skilled attendants to manage patients and to prevent and detect complications. It requires education, training, and more importantly, clinical experience. The doctors' trainees learn on the job while they are doing procedures or while assisting. They progressively learn more complex tasks under supervision of a teacher. Due to the sensitive and often emergency nature of obstetrics, students become observers rather than acquiring a functional role. They get less opportunity as a hands-on to manage obstetrical cases. Simulation-based teaching involves creation of true-to-life learning environment that mirrors real-life clinical scenarios. It is considered as an effective way of transferring skills to trainees. Simulation-based learning allows students to learn clinical skills in a safe, standardized, and controlled environment. It also gives the students a more hands-on experience, and the skills can be rehearsed without untoward negative effects on patients and avoids any safety and ethical concerns. When the resources are depleted by a number of patients where the patient load is less, and also helps in addressing medico-legal environment. It helps to build up interpersonal communication while they are working in the team and also develops leadership qualities. It helps the students in decision making and they are able to prioritize tasks. Also, they are able to manage stress which they face during real life patients dealing. The disadvantages are some, like it does not give a true picture of real life situations, so there could be defective learning, and also the attitude of learners may not be as they would have when they are dealing with real life patients. Cost factor is there because the mannequins and the simulators are expensive. Time factor is also involved because when we develop teaching modules, it is time consuming. Infrastructure is required in the form of expensive mannequins and models, and there could be technical difficulties as well. Therefore, training through simulation should be viewed as an adjuvant and not a replacement for learning with real patients. So we have developed a simulation-based teaching learning module in obstetrics for active management of third stage of labor. This module or learning can be assessed by direct observation of procedural skills, which is also known as DOBS. The simulation involves briefing, running of the clinical scenario, debriefing, and then question answers. The briefing part involves introduction of the teacher as well as the students. The learning objectives are well defined and the students become familiar to the environment. That is the learning environment. Then is the running of the clinical scenario, which can be observed by the other students or participants as well as the facilitator. Next comes the most important, which is the debriefing part and is the longest part, where we discuss how the clinical scenario was run, what were the mistakes or the deficiencies, how differently it can be done, and what are the positive and the negative take-home messages from the clinical scenario. This is followed by question and answers. So now I will be talking about the module which will be on active management of third stage of labor. And this is basically on the WHO guidelines. So the learning objectives for this module was that at the end of session, each participant will be able to demonstrate the clinical skills for performing active management of third stage of labor on a mannequin or model. And second is to describe the three components of active management of third stage. The assessment would include direct observation of procedural skills on the model. So firstly, we define the components of active management of third stage of labor. First is the administration of uterotonic drug within 1 minute of delivery of the baby, controlled cord traction followed by uterine massage after delivery of the placenta. So in administration of the uterotonic drug, palpate the uterus to make sure no other baby is present in uterus, especially if an ultrasound of the mother has not been done previously. Many patients who come to us from rural areas or patients who have not had regular antenatal checkups, they miss on doing an ultrasound. So that is why this step is important. Second is administration of a uterotonic agent within 1 minute of delivery of the baby, which is done by oxytocin, which is given 10 international units intramuscular. The second component is controlled cord traction, which has been described in the video which will be followed, how it is delivered by controlled cord traction. The third component is uterine massage, and that also will be shown in the video. The clinical scenario was given to the participants as Mrs. X, who delivered a female baby by vaginal delivery. Her second stage was uneventful. Baby cried immediately, and the birth attendant has just delivered the baby, and now the participants would have to manage third stage of labor. So this is followed by a video in which we will show you the briefing, the clinical scenario, and debriefing part of this active management of third stage of labor learning module. So to run the clinical scenario, we have to set up the model and on which the students can practice. There's a practice checklist which has the various steps according to the guidelines, and the steps can be checked and rated. So if a student does not perform the step correctly or is unable to perform, they are given 0, and a number of 1 is given if they perform the steps or tasks completely and correctly. So they can rehearse on the model number of times and gain confidence. So this is a practice checklist which has been made. Then the students can be evaluated according to the checklist, and they can be again rated whether the steps are being done in a sequence and whether it is being done correctly. So now we will run the video on which the clinical scenario is given, and it also includes briefing and debriefing parts. Good morning to all. Today's session will be on simulation-based teaching and learning on active management of third stage of labor. I will be the facilitator and my postgraduate students are the participants. They will introduce themselves.
Good morning, I'm Dr. Jacqueline.
I'm Dr. Stuti. Good morning, everyone. I'm Dr. Nupur. I'm Dr. Sonal.
I'm Dr. Barbie Sharma.
I'm Dr. Mandeep.
So today's learning objectives will be: each participant should be able to demonstrate stepwise the clinical skills of active management of third stage of labor. Also, they should be able to describe the 3 components of active management. We have a clinical scenario. Mrs. X has just delivered a baby vaginally. The mother is stable. Baby has cried immediately. Vaginal bleeding is average, and there are no complications. The necessary drugs like oxytocin, misoprostol, instruments like clamps and scissors, and we also have the neonatal resuscitation trolley by the side. Ambu bag is there, and we have the emergency drugs, laryngoscope, endotracheal tube, NG tube, antihypertensive drugs, and cardiac monitor by the side. So now you have to perform the clinical scenario and demonstrate the steps of active management of third stage of labor.
Okay, we'll be demonstrating active management of third stage of labor. It has three components. The first one is administration of uterotonic agent, second is control cord traction, and third uterine massage. Once a baby is delivered, we palpate the uterus to rule out presence of any other fetus. And then first step of active management of third stage of labor is followed, that is administration of injection oxytocin 10 units IM, which is a uterotonic drug of choice. Secondly, we do control cord traction. After first we clamp the cord and cut it using sterile scissors. Baby is then handed over to the neonatologist. Signs of placental separation are looked for, which are suprapubic bulge, lengthening of the cord, and sudden gush of blood. For control cord traction, For control cord traction, cord is held between index and middle finger, and downwards and forwards traction is given. The other hand gives counter traction to the uterus in upwards and backwards direction. Once the placenta reaches the introitus, placenta is rotated in a clockwise or anti-clockwise manner so that the placenta is removed completely along with the membranes. It's kept in the placental tray for later examination. Third step of active management is performed, which is uterine massage, wherein the uterus is massaged in a clockwise or anti-clockwise manner over the uterine fundus. Once the uterus is well retracted, we look for any perineal lacerations or tears, which can be repaired accordingly. Placenta is then examined by holding the placenta in both the palms with maternal side facing upwards. Any missing cotyledon is checked and uterine cavity is then explored. To look for completeness of membranes, placenta and membranes are hanged downwards by holding from the cord. The other outstretched hand is used to look for the completeness of the membranes. Okay. So that's how we have managed this patient in a third stage of labor actively.
So is the task completed, if you think it is completed?
Yes, I think, ma'am, we have done all the steps correctly.
So let us sit down and debrief. We will discuss how the scenario was performed. So please take a seat. Let us discuss on debriefing part. How do you think the scenario went? Do you think it was performed stepwise in a sequence? And how do you know that it was done properly?
Yes, ma'am, I think we all performed the steps correctly in a sequential manner. Basic steps were covered, and if we can do it repeatedly, we will be well versed in the whole procedure.
Nupur, do you want to add anything more? Do you think it could have been done differently?
A bit of natural environment could have been created. It's like we could have asked the baby status, is the baby doing fine, baby is healthy, ask about the patient, is the patient fine, is she perceiving any pain, take the vitals of the patient so that we need to check that.
We could have asked about the baby and informed the relatives regarding the status.
Maybe the communication should have been better with the patient. You need to ask her if she is having pain, ask her if she is feeling okay, and keep communicating to her. Would you like to add anything else besides this?
Ma'am, I think if we get a chance to do it repeatedly and frequently, we will be all well versed in doing it, and we will be able to manage patients when we get a scenario.
So I think you have all performed very well, and you have learned the steps of active management of third stage of labor, and now you can do it sequentially according to the WHO guidelines. and this can be done on real patients as well, and that is how you gain more confidence and you can move on to performing on real patients. Thank you so much.